you want to have metabolic flexibility. And when you do the same thing every day, initially you're going to see results. Just like if I ran 3 miles every day, at some point running 3 miles is going to do nothing for me because my body is going to adjust. That's like lifting weights. You have to increase the weight. You can't just once you get to a certain weight. So same thing with what you eat.
Welcome to the Dr. Ashley Show.
Welcome to the Dr. Ashley Show. I'm Dr. Ashley, and today I'm excited to share with you a guest episode where I interviewed Dr. Tara Scott. She's also known as the Hormone Guru. And Dr. Scott helps people find the cause of their symptoms and gets them on the path to optimal health. She's got over 25 years of experience and 3 board certifications in OB-GYN, functional medicine, and integrative medicine. So she knows what she's talking about. She's helped thousands of patients struggling with hormone issues, including endometriosis, breast cancer, weight gain, and a lot more. She's the founder of Revitalize Medical Group and the Hormone Guru Academy, which is a course that helps patients improve their hormone problems themselves. After suffering from infertility and endometriosis, she now helps others achieve that same balance. Dr. Scott has been speaking, including a recent TEDx talk that I really enjoyed listening to, and she's been educating for over 10 years and has taught doctors her approach in 5 continents. For her expertise, she's been featured on The List TV, Women's Health, Shape, Newsweek, Parents, Authority Magazine, and on numerous podcasts. So without further ado, I'm so excited to welcome Dr. Scott to the show. Dr. Scott, welcome to the show.
Thanks for having me.
I'd love for you to start by just sharing a little bit about your story and your journey from practicing OB-GYN to becoming this leading expert in hormone and integrative medicine. If you'd share with us that pivotal moment in your life where you realized the importance of focusing on hormonal health.
Yeah, so I was a traditionally trained OBGYN and really loved delivering babies and all that comes with that. But when it came time to start my own family, I struggled with infertility. And thankfully, due to modern medicine and fertility drugs, was able to have a family. So when you're a woman experiencing hormone disorders, if you're trying to get pregnant, we've got treatment for you. But if you're not trying to get pregnant and you don't need to prevent pregnancy, there's really nothing for you. And there's this kind of void. So it got me more interested in learning in reproductive endocrinology. And that was right around the time where the Women's Health Initiative came out, which is a big study on hormones that shed a negative light. So it really caused me to do more digging deeper. So I started going to courses and learning about hormone therapy. This was 20 plus years ago. And then the kind of next thing that happened that made me completely want to shift into wellness, prevention, optimal health is my brother suddenly passed away at 38 with a heart attack. And so it was a shock to everyone because he wasn't really sick. But after I kind of dug a little deeper, he had every risk factor. He was a diabetic, he smoked, he was a lawyer, so he was stressed, he was sedentary, he was on a statin. So I felt like, wow, this was a totally preventable death. And I felt like I really wanted to change how I practiced medicine and see about getting people healthy or well before they were sick. And really back then, this was 20 plus years ago, there wasn't as much research for the hormone world, and there really wasn't as much focus on that. So it's really been amazing to be on this journey and now see so much more as far as people who want to get providers who want to get extra training in menopause. And that was the first thing I did. And then I did functional medicine training with A4M. And then I got another board certification in integrative medicine. So now there's so much available. And as a matter of fact, we just got approved from the University of California, Irvine to do another functional integrative fellowship. So I'm going to head up the women's health section of that. That's going to be another option for practitioners who want to dig deeper and do the education. So yeah, it really just changed the way I focused everything. And so now what I do isn't really just menopause, but it's really all ages, like from teens, women in their 20s, 30s, with any kind of hormonal issues.
Wow. A lot of study there.
Yeah.
When it comes to the Women's Health Initiative, what would you say are the biggest misconceptions that came out of that?
Well, the first thing to know about that study is the Women's Health Initiative was a large body of like data collection, just like the Nurses' Health Study. So they ran a lot of studies out of that. They would just basically gather these cohorts and in that collect data about them, and then they could do studies that. The purpose of the study was not to see if hormone therapy was safe. At the time, there were 4 indications for hormone therapy. One was prevention of osteoporosis. The second was vasomotor symptoms or hot flashes. The third was something called genitourinary symptoms of menopause or vaginal dryness, painful intercourse. And the fourth was if you have premature menopause prior to the age of 45. Those were the reasons according to the FDA. So they were actually looking to get their product a 5th indication, which is primary prevention of heart disease. The study was not done to say, is this safe? The study was done to say, hey, we think our product can prevent heart disease. Everyone should take our product. And the FDA is going to say, well, prove it. Well, think about that. If you say your product prevents heart disease and it's the number 1 killer in women, number 2 is stroke, number 3 is lung cancer, number 4 is breast cancer. And if you add up 2, 3, and 4, you still don't equal the amount of deaths from heart disease. So they would get the indication for everybody to take their medication. Right? So, but nonetheless, they set out to do what's called a randomized placebo-controlled trial, meaning that some people got the drug, some people got a placebo, and there were only 8,000 people in each study, each arm, and they saw that there was an increased risk of breast cancer and blood clots. So since then, I bet you if you polled 10 family practice doctors right now, 9.5 would say hormones cause cancer and don't take hormones. And I think the same would be true for gynecologists, honestly. So thankfully, there's been a lot in the media. Some stars have gone through menopause. So now they're sharing their experience. And now with social media, you can get more information out there. The consumers are looking for it. So the pendulum has swung back around for about 5 or 10 years after that study in 2002. Hormone therapy was very, very negative. And then they came out with these studies that say, here's what we experienced because people didn't take hormone therapy, more heart disease, more osteoporosis, more death because of all these things. So I think the thing to understand, first of all, is the aim of that study, right? And then that what was studied is really not used as much today. I'm hoping it's not used at all, but I know some people still use it. It's an oral estrogen from horse urine. That's a combination of a lot of different estrogens. And then it's a synthetic progestin. So it's not native to our body. It's different than what our body would use. And so we have some great, even FDA approved generic bioidentical hormones that people can use. And so the risk doesn't apply to everything. So that's the other point, is that the risk doesn't apply to everything. And above all of that, the Menopause Society says that between the ages of 50 and 60, taking all the studies into consideration, unless you personally have breast cancer or a reason that you can't take hormone therapy, you have more benefits for taking it than you do risks.
Mm-hmm. So then you would recommend women within that age group who don't qualify for being high risk should be on HRT?
Well, what I recommend is every woman should be assessed. I think every woman should be told of the risks and benefits. It might not be for everyone, right? But I think everyone deserves the chance to, in my mind, first of all, find out it's not also standard of care to check hormone levels. So yeah, I think everyone should find out, what is their body making? What are they not making? Do they need it? Number 2, what are their individual personalized risks for taking or not taking, and what are their benefits? But women still aren't getting that choice. Some of my patients and some of the people on social media are saying, my doctor said I shouldn't take it. Well, the doctor shouldn't make the decision on whether a woman wants to take hormones or not. I mean, if the doctor isn't comfortable prescribing, that's completely their prerogative. They shouldn't be asked to prescribe something they're not comfortable with. But they shouldn't tell the patient, you shouldn't take that, right? Mm-hmm. And they should say, I'm not comfortable, I don't have experience, go to so-and-so, for that.
Mm-hmm. So many listeners in this age group are likely dealing with some kind of hormonal changes related to menopause, perimenopause, andropause. How can they balance their hormones and, improve their overall health, maybe drop some weight? What would your suggestions be?
So the biggest subset really is that perimenopause, because I think menopause is getting more attention, and menopause is 1 year without a period. So people know they're in menopause, right? Mm-hmm. But people don't know they're in perimenopause. I mean, you can really start early in your late 30s, honestly, with hormone changes that are related to aging ovaries. And you're absolutely right. I mean, weight gain is something that is very prominent at this age. What happens in perimenopause is you're born with so many eggs. The eggs are old, so the brain has to increase the signal of FSH to stimulate ovulation. With that increased signal, you get more eggs recruited and more estrogen. But you don't get more progesterone because only one egg can ovulate, and these are old eggs, so they don't produce as much progesterone. So you naturally have a discrepancy. Estrogen is a growth hormone, which is good in some ways, right? Luscious hair, skin looks good, but it makes other cells grow: breast, uterine lining, hips, adipose tissue. And you don't have that balancing hormone, progesterone, that is like a diuretic that counteracts that growth. So women, there's no amount of caloric restriction and increased exercise that's going to help that if you're not hormonally sound. And they're being told, just eat less, exercise more. They're in a caloric deficit, which increases their cortisol. And then that's going to make haywire with their blood sugar. So they're frustrated. And I think they get to the point where, and I remember the same thing happened to me. And I'm like, I have the access to check my hormones whenever and balance my hormones. But I just remember certain times, perimenopause, even like in the late, I'm not even menopausal yet, but I'm like gapping my periods. Weight comes on like that, like right away. I've consistently for the last 20 years of my life, run 20 plus miles a week, get to the gym, vigilant about my, macros and everything, and sleep and everything. So those are some of the things that are really helpful to balance your hormones naturally, making sure you're moving, making sure you're sleeping, and prioritizing how you're letting stress affect you. And then also the macros, the food timing, and the macros of what you eat as well.
I was talking to a client at PhD yesterday, and she's 50 years old. And I said, you're at that time, that life stage where you probably should get your hormones checked. I would recommend that. And she's like, well, if I had hormone replacement therapy, don't hormones make me fat? What would you say to that?
So, that is partially true, partially not true, right? Because first of all, when you're taking those synthetic hormones, that what is traditionally given, Prempro, that does make you gain weight. It's a synthetic estrogen. There's 3 types of estrogen in our body. One's estradiol, one's estrone. Estrone is made in the fat cells. It causes water retention and weight. Right. Estradiol is made from the ovary. That's what we traditionally replace in hormone replacement. But Prempro is predominantly estrone. So people do gain weight on that. The synthetic progestin also makes you gain weight. Like when people take a birth control pill, they gain weight. When they have a progestin IUD, there's usually 5-ish pounds of weight at least from the synthetic progestin. So I would say it was true with that type of hormone. With the different types of hormones, it's dose related. So if I said, I'm going to start you on bioidentical hormones, but I way overshoot the dose, yes, it's possible that you could gain weight. But if we're personalizing the dose, so that's the other problem with, we do have menopause practitioners traditionally that are willing to prescribe hormone therapy instead of telling you not to. But that the standard of care is still not to check hormone levels or monitor. Because if you look at the guidelines for men, andropause you mentioned, it's check hormones, give testosterone, monitor. Even the guidelines for transgender hormone therapy is check, give hormones, monitor. But for women, don't monitor. Hormone levels don't mean anything. Just give the hormones. And then if they have a symptom, adjust as necessary. That can be very frustrating because the symptoms of low estrogen and high estrogen, you can gain weight if you're low in estrogen. You can also gain weight if you're high in estrogen. It's not always in the same place because menopause is usually that menobelly, and usually estrogen dominant weight would be on the hips, chest, a little bit in the back of the arms. It's traditionally a little bit different weight, but it doesn't matter. I mean, it depends on your body type and ethnicity. You might always be someone who gains it in your stomach. Yeah. I mean, that's how I am. I almost never gain it in my weight in my arms and legs, but it's always in my stomach. So it's not always true that it's a certain time of, your life that you gain at a certain place. And
for men, would you say most men should be considering testosterone?
Well, and that's the other thing. A similar thing happened with testosterone. There was a study, and I don't have the dates memorized as much as I do for women's, but there was a study on testosterone that was very negative light. And it was probably about, I'm going to guess, 5 to 7 years ago. So since then, that study has been debunked, right? And so there are studies that show there is an increase in mortality of all causes when you take out smoking and heart disease with low testosterone in both men and women. So I think the same thing. So men don't have like the onset of menopause, like no period for a year to tell them their hormones could be low. And we're actually seeing men in their 30s and 40s with low T because it can get depleted faster with chronic stress. So I do think the symptoms and people, they should have the opportunity to have their hormones checked if they want to.
Yeah. I find that a lot of men are low in T also when they carry a lot of belly fat, because that belly fat secreting aromatase, converting their testosterone into estrogen. So now we have these men who are overweight, belly fat, super stressed, adrenal fatigue, and their hormones are just shot.
Exactly.
How do we tell if weight gain is coming on due to hormonal issues or other factors like diet or lack of exercise? Are there specific tests or assessments that people should consider?
So as you know, as someone who works with people with their weight, the intake is going to tell you a lot of things. And when we see patients, we do a detailed intake as far as, not only their personal history, family history, whether they're cycling or not cycling. We get a 3-day food diary from them. And I ask specifically about food timing and what they eat also. And then stress and sleep. We ask them about all those things. Every one of our patients at their intake, we start with blood work. Most likely, especially if they're still cycling, we'll measure female hormones in the blood at a specific time of their cycle. We get these labs fasting. We always do a full thyroid panel. Not everybody checks the full thyroid panel, and your TSH isn't always adequate to monitor because it can be affected by your cortisol, by your estrogen. So we get a full thyroid panel, and we also get a metabolic panel. We're checking fasting glucose, an A1C, and a fasting insulin, and some other metabolic markers as well, like leptin, CRP. And so we're kind of assessing their blood work to see, do they have inflammation? Do they have metabolic issues? And I'm so surprised at the amount of people also that I see in the pre-diabetic range who their doctor said, oh, when you get diabetes, we'll treat you. You're 5.9, you're 6.2. And so again, having a brother who died from diabetes, I'm like probably a little too much on edge about this. And I tell that to people, I'm a little sensitive about this because I don't want you to get diabetes, but we need to intervene. So, then we have health coaches in our office that will also do a little bit more deeper dive into what they're eating. In that pre-diabetic population, we like the continuous glucose meter, at least for a 2-week trial. So people can see, I was a pre-diabetic and family history of a lot of people with diabetes. And this was me running marathons and, doing all this stuff, but I was probably eating pairing wrong. It was hormones. It was a lot of things. And even still, just this last, year when my periods have been very sporadic, I put on weight. So I got the Lumen. Have you seen the Lumen device?
Yeah.
Okay. So I have never been more vigilant in 90 days as to logging what I was doing. And it never let me have many more than 45 grams of carbs.
Yeah.
Unless I ran, then it would give me like 75, but barely ever more than that. And I was pretty much trying to stick to it. If I was eating more carbs, it was those vegetable carbs that it doesn't count. And I thought, okay, my A1C is going to be good. It was 5.2. It went up to 5.7. After 90 days of me, I said, I have never been more strict with carbs in my life because I run and I think, and in my carbs, I don't eat gluten because I am sensitive to it. So the carbs that I'm eating would be like starchy vegetables, root vegetables. I'll eat potatoes too, but I'm not like I'm eating bread and cake and pasta, So it's crazy how hormones can affect that. Here was a perfect example of I was like, I had never been more strict than I was in that 90 days. And mine went from 5.2 to 5.7.
And your takeaway was because your hormones were imbalanced.
Well, I think part of that, a lot of it is hormones, but also it's my genetic predisposition. It's just my body chemistry. It's just like I'm Hispanic and Indian, two populations that have high diabetes.
Mm-hmm.
And so, no amount, there's some people that just is what it is. So you need to do all this extensive monitoring, because if I never went in, nobody would know. And I would just be doing the same type of things. And, my A1C would be going up. And my dad, knowing that what's happened, with my brother and everything, his A1C has not been great, but, he's thin, he exercises, he's 87 years old now, not a diabetic yet. And so he's been really careful about, but, his cholesterol isn't great. And he's really, really good about his eating, and he's super thin. So there's certain genetic predispositions.
Yeah. And like you say, stress too. Maybe in those 90 days, I don't know what your stress levels were.
You're right on that one. That was high. Yeah, that was probably the culprit.
Yeah.
Hey guys, quick interruption to the Dr. Ashley show. After a decade of helping thousands shed pounds, I realized the need for an electrolyte mix tailored to support lean muscle mass and metabolic needs. People always talk about electrolytes for different sports or lifting weights, but what about for weight loss? It's a marathon of its own. Drumroll please, introducing Electrolyte Plus, your marathon champion. Packed with patented ingredients for optimal absorption, it fuels metabolism, supports adrenals, and stabilizes blood sugar. Say goodbye to those headaches and lightheadedness. Visit drashleywellness.com and use code Ashley10 for 10% off your first purchase or 20% off your first subscription order with free shipping. Plus, enjoy a 30-day money-back guarantee. Back to the show.
It is wild. People don't think about the impact that stress has on our blood glucose, our weight, and it is significant. I'll have people come in to our clinic and they'll be eating all the right things, doing everything right, can't drop the weight, and we talk about what's going on in their life. And that and sleep, I would say, are two big things we don't take seriously when it comes to our health, but really, unfortunately, impacts it.
Yeah. And I think the worst part is if you're someone who's had a fair amount of stress your whole life, as most working moms, you might not even realize that if it's a little bit more, you might think, oh, I'm a little stressed, but you don't even realize how much that change can affect, because, your brain doesn't know if you're running from a bear or if you have a deadline at work. So, yes, you're right.
Yeah. I was talking to my son, he's 12 years old, and I've been having some inflammation in the gut for some reason. I can't figure it out. Like you, I eat super healthy, not a ton of carbs, protein. And he's like, it's stress, Mom. I was like, do not even say that to me. My life is not stressful. He's like, you're stressed right now. Your whole life is stressed. So sometimes it takes someone else to say, like, you actually are stressed, even if you don't think you are.
Right.
You did a great TED Talk. I really loved it on stress. And I would love for you to talk about stress and weight gain. And then what would your suggestions be, say, to someone like me who kind of lives a stressed life? I like it a little bit. I know I thrive on a low level of stress at least, but I'd love to hear what you would suggest for us.
Yeah. And so again, it's so interesting how, you might be working with a client that you don't think has a stressful life, and they get stressed very easily. So that's either because of the way your HPA or the brain and the adrenal gland develop. I think sometimes when moms are pregnant, I think that sets the stage for some people, because I've worked with people that I don't think their lives are that stressful, but they're very stressed. So how you perceive stress is really what's important, because as I mentioned, your brain doesn't know if you're running from a bear or if you have a deadline at work. So the job in that stress response is to get your blood sugar up, because you have to fuel your muscles so you can run. And so then insulin comes along and insulin says, no, you have too much blood sugar. Let's get you down. And then in that stress, sometimes you have glucagon come up. And so that can have this yo-yo of your blood sugar, where at low blood sugar, you're going to store fat because your body doesn't know when you're getting fuel, or at high blood sugar, you're going to store fat also. And so many people also, because the American diet is so much carbs, are becoming more and more insulin resistant as well. So the issue with stress is, I used to tell people to reduce their stress. But what I found with myself, because I thought, okay, for sure, my life is stressful. I had twins, I have 3 kids in 3 years. So it must be that I have 3 kids. Well, then I'd look at other people that had 3 kids and that wasn't the issue. Then I'd be like, it must be because I'm delivering babies and I'm up at night. So let me stop delivering babies and my stress will go down. There's always another stress. And I feel like I'm someone who doesn't get stressed. Like you, I can handle stress. I can handle a lot of stuff. I'm a multitasker. And I pride myself in being able to persevere and get things done, right? I mean, hey, I can cut a baby out in a minute in an emergency C-section. So I just have had that training. So I think the important thing to know, first of all, is to not underestimate how stress affects you. And if I would advise somebody like you that can handle stress and maybe doesn't feel stress, like I said, not to underestimate it, but get whatever it is for you that works for stress. I mean, we have a lot of data on meditation and yoga. And at one point, I was really great at meditation. I don't know what my problem is now. I like it. I love the Headspace app. I just can't get myself I'm not sure what, I don't know what the issue is. And so I have fallen off the wagon. I love heart math, which is a kind of biofeedback, which isn't really much more from breathing. So if you're someone who does breathing, but there's a lot of data on heart math, a ton of data. Or I've been recently telling people like, hey, you know what? Like your pet, if you want to sit with your pet and hug your pet, hug your kids, whatever. I think it's that, dialing down from the go, go, go. Our society has become, what do people say when you're like, how you doing? Good, good, busy, busy. Like you would feel guilty, not guilty, but if you said, oh, I'm not that busy, I'm not working that much, you probably would feel bad, Like I have this thing drilled into me probably from immigrant parents that we got to work, we got to, do stuff. And like I said, I mean, I was at every kid's stuff. I was on the board of show choir. I was a travel director. I was the head swim timer. I coached cross country. I did all this all while running a practice, right? And, and again, I am thankful that I could be there for my kids, but I mean, did I need to do as much? I think I went overboard because I felt like my parents didn't come to anything. And it was a different time. And again, like I said, being immigrants, they didn't understand that. But I think America has gotten to be so much worse, right? It's like everybody's in travel this at like 6 years of age.
Yes.
And travel sports and dance and this. And if you don't do it, they will keep going and your kid won't get that opportunity, right? So my sister had kids a little later. So her daughter's 15. And same thing. She was like doing JO volleyball. She was doing it at school and she was getting stressed. And so finally my sister said, are you going to play volleyball in college? And she's like, no. She's like, well, then why are you getting all stressed out about doing this thing that we have to drive 2 hours one way to get you to practice?
Crazy.
And do that. And then she wisely said, we're not doing that, but I don't think people do that because they feel the pressure that if they don't do that, their kid's not going to get the opportunity.
Yeah, I feel that right now. I have a 12, 11, and 5-year-old, and they're all starting up fall activities. I'm like, okay, I'm bracing myself for it. Add this all in.
Because with 3 kids, you got 2 parents. So there's always that other one. Well, who's got this one? If I take this one and this one, and my twins were a boy and a girl, so they weren't in the same activities necessarily. So it's like, well, who's going to get that one then? So you're outnumbered.
That's true. I'd love to dive in. We talked a little bit about nutrition, carbs. You mentioned that when you have patients come in, you look at their macros. What would just be some baseline guidelines you would give when looking at nutrition to optimize health and hormones?
Yeah. So of course I'm not a dietitian. So this is just based on my study of the physiology and how hormones affect it. So I have 2 basic observations, maybe 3. Well, women eat a lot of carbs, right? Or Americans eat a lot of carbs.
Yeah.
And so if you think about what the standard American diet's, cereal for breakfast or a bagel or muffin or English muffin, sandwich for lunch, and then meat and potatoes for dinner. So we're getting a little bit better. So that's the first thing is I think you become very carb sensitive. So there's something about estrogen and insulin and carbs that when you start having fluctuating levels of estrogen, you become much more carb sensitive. So I always want patients to be conscious of the carbs that they're eating, the better carbs versus the ones that are really going to spike your blood sugar, like white sugar and bread and that kind of thing. Plus it's inflammatory. The other thing is women don't eat enough protein, right? I mean, I could, if someone cooked for me and they never gave me meat, I would be fine, right? And if they gave me this delicious macrobiotic meal with the right kind of protein, I could take or leave meat. I eat meat, I'm not against meat. I eat meat because I can't get enough protein, and so I'm trying to do the protein shake. I don't feel like I'm getting enough protein. So I think a lot of women don't eat enough protein. And the third big thing is food timing. I'm sure you've talked about that on some of your videos too.
Yeah.
I see like it's getting better because, time restricted feeding and intermittent fasting is the rage, but somewhere somebody said eat 3 meals and 3 snacks. That drives me crazy because we know that it takes 4 hours for your body to process the sugar and come back down your insulin and glucose and glucagon levels. So if you're doing this, your waking hours, you're doing 3 meals and 3 snacks. Naturally, a lot of people are kind of shying away from the breakfast. And I've never been like, you have to eat breakfast person, so if they choose not to, and they want to extend that overnight fast, it's super important to be at least 12 hours most days. If they want to do 14, 16, a couple days a week, and I don't know what you think, I don't know that there's much more benefit for 20, longer, and especially every day. I think you want to have metabolic flexibility. And when you do the same thing every day, initially you're going to see results. Just like if I ran 3 miles every day, at some point running 3 miles is going to do nothing for me because my body is going to adjust. I mean, it's going to do something. Don't get me wrong, but it's no longer going to really do the same thing. That's like lifting weights. You have to increase the weight. You can't just once you get to a certain weight. So same thing with what you eat. I encourage women to do a couple days a week, maybe 14 hours. And really that late night eating is a killer for people.
Yeah, I agree with you. I think skipping breakfast once in a while is fine, and making sure when we do that, we're still getting adequate protein. For me, if I don't eat breakfast, which is my natural tendency, if I didn't have to eat, I would prefer that in the morning. But then I'm short on protein. It's so hard to get it all in there.
That's true. And, we're working with a lot of people who have Hashimoto's thyroiditis, which a lot of them have non-celiac gluten sensitivity as well. So we're telling people not to eat gluten.
Yeah.
Not to eat dairy for inflammatory reasons. So breakfast is all gluten and dairy, unless you're going to do eggs, if you can tolerate eggs. And I have a kind of a low level intolerance. So I can't eat them every day. I could have them maybe once a week.
Can we talk about thyroid a little bit? Because I know the general care of thyroid likely isn't adequate for most people. When someone comes into you, what would you test? What would you look for?
Well, the main thing is that there are some practitioners that will do a screening for TSH. And I'm going to tell you, this is not standard of care. But one of the things to remember about your TSH is it's not a thyroid hormone, it's a pituitary hormone. It is supposed to be indirectly proportional to T4. So your thyroid makes T4, and then your body has to convert it to T3, and that's the active form. So I tell patients, think about your TSH being what you're clocking in. Your T4 is your paycheck. You can't walk into Walgreens with your paycheck. You have to cash it. And when you cash it, you're going to put some in your 401k. So your 401k is your reverse T3. You have it, you just can't use it. So you've got this balance between T3 and reverse T3. And reverse T3 is like a bouncer that's going to sit on the receptor. So T3 cannot work. So if you are just looking at TSH, one of the things to remember is that high cortisol, which we've just said a lot of people have high cortisol, will suppress the release from the pituitary. So you will have a falsely low TSH. In other words, it will look like your thyroid's normal when it's underactive. And it might even look like you're hyperactive when it's underactive because your TSH is low. The other thing I see is the conversion from T4 to T3. There's a lot of things that affect that enzyme. How much iron you have, what your vitamin D level, and where I live, everyone's low in vitamin D in the winter unless they take it. It's too high or too low cortisol. So if you have a normal T4, but you're not converting it to T3, again, that's what's active at the receptor site. So it's 300 times more active. So then you throw estrogen into the mix, right? So how does estrogen fit into all this? Well, estrogen will increase when it's high a binding protein. It increases sex hormone binding protein, it increases cortisol binding protein, and thyroid binding globulin. So if your provider is checking a total T4, it might look like it's normal, but you're free That's what's available to work at the receptor could be low because estrogen is high. So in any woman, you always have to check a free T3, a free T4, TSH. We will check the reverse T3. We'll check thyroid globulin antibodies, which can be affected by lack of sleep and stress, and thyroid peroxidase antibodies, which are the antibodies that are from autoimmune thyroiditis. If someone has they're not positive with the antibodies, we don't necessarily keep ordering that. And I don't always order the reverse T3. I mean, if everything was free, I would order all of it all the time. But again, it's not. So the minimal I would check is the TSH, the free T3, and the free T4.
And then what kind of treatments are people looking at if those are off? I mean, I guess it just depends on what one is low.
Well, if we think it's a subclinical hypothyroidism secondary to cortisol, obviously we're going to try to fix cortisol. And if it's secondary to estrogen and they're estrogen dominant, sometimes just giving them progesterone has fixed the amount of free level, so the free goes up. So that we're going to try to isolate, like, what is the root cause? It could be, as I mentioned, a non-celiac gluten sensitivity. People get off gluten, their antibodies go down. Could be gut bacteria. So we do stool testing with PCR testing for microbiome, and we see, they're not infections in your gut because you have a certain amount of bacteria that's supposed to be there. And if you have an overgrowth of the bacteria that's supposed to be there, it's not unusual to be there. It's not an infection, but it's a dysbiosis that can affect your thyroid. We're seeing a lot of the autoimmune diseases linked to gut issues. Yeah. So we would look at that for a thyroid person. We would they could start with just getting the nutrients and working on cortisol. We have all kinds of options for thyroid replacement. If they're needing that, we could do, we do traditional thyroid replacement. Levothyroxine is bioidentical. So we will use that. We will use desiccated thyroid or armor thyroid. That's from a pig, but that's a fixed ratio of T3 and T4 that isn't always right for everybody. And then we can use a compounded version where we can kind of dial in exactly what people need in a personalized thing. Because if they're not making that conversion to T3, that could need to be addressed.
Yeah, thyroid is complicated. That's the summary.
And I think it's complicated, but it really is, I think it's so much less complicated than menopause or perimenopause, because the issue is if everybody did the whole profile, I mean, it's covered, knock on, it's usually covered, it's available. It's not like it's testing that we're not familiar with, like urine or saliva testing for hormones. It's like, it's there. You just order it. I have yet to tell a patient that it hasn't been covered. Unless they have some other issue that's like a high deductible, but like it's covered with the diagnosis. And the other thing that I see is, like, if I'm working with a patient that's on thyroid hormone, like, it matters. Are you checking what's called a peak level or trough level? Meaning, like, do you want to get them when they're on the thyroid hormone, or do you want to get them when they're not? Like, a lot of my patients, like, nobody ever told me. I said, do you take your thyroid and then get the labs drawn, or do you hold your thyroid? Well, I don't know. I just go. So that makes a difference. If you take a medication and then you check it, then that's a peak, and that's fine. You just have to know which one you're doing. If you want to check the trough levels or you want to check the peak levels. So people aren't intentional about that. I guess I'm just a detail person about those things.
No, it's very true. Yeah, because I'm on a low dose for hypothyroid. And I generally don't take the medication before I get tested, but then one time I did. And so my levels are all over the place as a result of that, actually. So that's
right. And I think where that stems from is the TSH doesn't change if you take it or not take it, because it takes longer for that to be affected. But if you're doing T4 or T3, that will change whether you take it or not take it. So we always want our patients to take it. I like to get the peak, take it, and then don't go any sooner than 4 hours after.
4 hours after you take it in the morning is when you need to
That's
get your
how I like to.
Interesting. Okay. The last thing I want to touch on is exercise. We talk a lot about not cholesterol, but cortisol. And I think that some of us sometimes work out too much in the wrong way, and that can elevate cortisol. So I'd love for you to chat on what is the optimal way to move our bodies to support good health, fat loss, or good weight maintenance, and keep our cortisol levels in check.
Yeah, that's a great question, a great point. As a recovering marathoner, I will tell you that
Yes.
when I first did my cortisol, I'm like, oh, I need to exercise for cortisol. Let me run 3 marathons in the same year. It's like, do you think that helped my cortisol? No, it did not. And that did not help my weight. I gain weight when I
Yeah.
do distance running,
Yeah.
not muscle. So the key is, I know you're going to hear everything. And I'm not an exercise physiologist. I'm not a personal trainer, but as a physician who works with women, I am a fan of the high intensity interval training. But the difference is, for you, if you go to the gym and you work out for an hour and you do a HIIT class and you go about your day and you're fine, that wasn't too much for you. If you go and do a HIIT class and then you're so exhausted the rest of the day that you have to take a nap, that's too much, right? And so it really is listening to your body. And I've really been trying to do that and be kinder to my body, because I was someone who would just go and do it no matter what. I have such extreme discipline. I would never miss a run, never miss a workout. I would do it to the detriment, right? And just really the last few years, even since our accident, I've just been like, I have to just listen to my body, decrease the amount of miles that I'm running, because, I'm not a Kenyan. I'm not ever going to be an elite athlete, right? I'm just not, right? So is this mileage really serving me? I mean, I like it because I have friends I run with. We ran 10 miles this morning. It's
Oh my
a
gosh.
social thing. Yeah. So for me, it's more social. And I also have an extreme fear of getting out of shape. That's my own issue, right? But what I've
Something
learned,
you're working on.
yeah. Yes, I have a lot of issues, but I'm an ectomorph. I don't have a lot of muscles, but I've really tried to concentrate on more muscle. Women after 40, they start losing muscle. So never was a weightlifter or anything like that. So I really, in my older age, I'm trying to address that. To me, that doesn't seem taxing. It's really hard for me to get my heart rate up. I mean, my baseline heart rate's in 45, so for me to go to the gym to kind of it's not really a HIIT class because it's not Tabata, but it's it's like a little cardio and a little lifting and like that. I barely sweat. And my friend will be like, you never sweat, but I'm doing the weights. But that is, I try to do that because that's what my body needs. And then, enough cardio for your heart. The American Heart Association says 150 minutes just to prevent heart disease, not for weight loss. So just for heart maintenance. I think for somebody with a cortisol problem, if it's exhausting you, it's too much. Now, if you had low cortisol and you have the luxury of being able to do a cortisol test, we do recommend a little bit of exercise in the morning because that can raise your cortisol because you need to raise it. So gentle walking, maybe some, jumping jack or squat thrusts might help you just a little bit in the morning. Now, if you're someone with high cortisol all day long, they feel better when they run or do something high intensity because it helps dispel the cortisol. So knowing where you are in the continuum can be helpful. But I don't think, unless you're totally overtraining, which can be, what we do is we tell patients to take either, I have an Oura ring, so I can get my baseline heart rate, or you can, do your pulse if it's up by 10%. So that means if my baseline heart rate, let's just say, is 50 and now it's 55, I really shouldn't be doing an intensive workout that day. That's 10% up. So I try to get people to do, what's better for them. If it's just walking. And the other thing that I notice is too, is if I don't exercise, then sometimes I do feel sluggish. I was on call for jury duty this week, so I missed several workouts because I had to wait to be available. And I felt I started really feeling awful. And I feel better today. I went for a run. So it just depends on the person. I don't think there's no HIIT ever for cortisol versus, you should. It depends on if you have high or low cortisol, which hopefully you'll be able to get that measured. And if you can't, I would say, do you feel tired and wired? That would be high, or tired and depleted. You cannot get going burnout. That would be low. And if you're working out and you feel awful, I had one patient who could barely get through her day. And she was walking on the treadmill for an hour on the weekends because she felt like she had to. I'm like, you know what? If you're exhausted the rest of the day, cut it to half an hour, decrease the incline, decrease the speed at which you're walking, but movement. I mean, I try to do something every day, even if it's a short walk.
Yeah. Dr. Scott, thank you so much for all of your insights, your time. where can we go to learn more about you and watch your TED Talk and all the great things that you're doing?
Yeah, so I also have a YouTube channel. It's either Tara Scott MD or Hormone Guru. So most of my social media is under Hormone Guru or Hormone Guru MD or Dr. Tara Scott, and you can find out, look at all my links there.
Thank you so much for coming on the show and sharing all your insights. I gained a lot, and I know that all of our listeners and viewers will too. So thank you so much, Dr. Scott.
And thanks for having me.
All right, you guys, I hope that you really enjoyed that episode. If you are watching this on YouTube, if you've got any questions about any of the aspects we talked about today, please drop those in the comments section below. If you are listening to this on a podcast platform, please leave a review. Your reviews, your comments, subscribing to YouTube really helps us positively impact more people. So remember, you guys, you've got to step up to make the change. Lead with your heart, train your mind, and do not negotiate with your body. I'll see you next time.